topic of my presentation is renal dysfunction. These are all objectives of my presentation: introduction, etiology of acute kidney injury, chronic kidney disease, clinical presentation, nursing and medical management, and references. I will cover all these objectives in coming slides in details. First of all, start with introduction. Basically, renal dysfunction is the inability of the kidneys to perform excretory function, leading to retention of nitrogenous waste product from the blood. Kidney failure is of two kinds, acute renal failure and chronic renal failure. And when a patient needs renal replacement, then the condition is called end-stage renal disease. In renal dysfunction, the risk and frequency are directly related to the method of BMT, with myeloablative allogenic BMT being associated the highest risk, followed by non-myeloablative allogenic and myeloablative autologous BMT. Move on to the next slide, that is acute kidney injury. That is the main type of kidney failure. Acute renal failure or acute kidney injury is the syndrome in which GFR declines abruptly, and this condition is usually reversible. Recently, the term acute kidney injury has replaced ARF because AKI, acute kidney injury, denote the entire clinical spectrum from a mild increase in serum creatinine toward renal failure. Acute renal injury is defined by the measures of acute kidney renal injury is defined by the measure of serum creatinine and urine output. When the serum creatinine is increased to 1.5 to 2 and urine output is less than 0.5 ml per kg per hour for more than 6 hours, then it means that kidney is at risk of injury. And when the creatinine is increased to 2 to 3 and urine output is less than 0.5 ml per kg per hour but more than 12 hours, it means kidneys the kidney injuries occur. Kidney failure when the serum creatinine is more than 3 and output is less than 0.3 ml per kg per hour for more than 24 hours, or anuria is more than 12 hours, then it means kidneys are in the condition failure condition, and there should be needs of initiation of replacement therapy. Next are causes of acute renal failures. There are 3 causes of acute renal failures: pre-renal, intrarenal, and the post-renal. And approximately 60% causes of acute renal failures are pre-renal, and pre-renals are associated with transplant associated and also non-transplant associated. In transplant associated are veno-occlusive disease, drug nephrotoxicity, tumor lysis syndrome, and also infusion of stem cells. We will discuss these causes in coming slides. And non-hematopoietic stem cell transplant associated are hypotension, volume contraction, and severe organ failure, such as heart failure and liver failure. Intrarenal causes of acute renal failures are approximately 35%, and these are also transplant associated and non-transplant associated. In transplant associated are tumor lysis syndrome, infusion of stem cell, and transplant associated microangiopathy. And in non-transplant associated, acute tubal necrosis, acute interstitial nephritis, and connective tissue disorder. These are the post-renal causes of the acute renal failures. These are all general causes of renal failure except hemorrhagic cystitis. Hemorrhagic cystitis, because in severe cases, can result back pressure and also can cause acute renal failure. The cause of acute renal failure is infusion of stem cell. Infusion of stem cell may result in acute renal failure in 2 special circumstances. First, in the case of major ABO mismatch, when the patient is taken for BMT without sensitizing. And when the patient is taken without sensitizing, it can result into severe hemoglobinuria and also cause renal failure. Here is the second cause is exposure to DMSO, which in originate we can only face it in the case of autologous backup, because of in originate of our transplant is hematopoietic, not peripheral mobilized BMT. That is also another cause of acute renal failure associated with stem cell infusion of stem cells. Acidosis and hypovolemia is also increase the risk of renal failure, and we can also prevent from this complication by proper adequate hydration and alkalinization of urine with adequate urine output. Clinical manifestation of AKI, acute kidney injury, lethargy, because the waste products are not properly filtered and is slowly accumulate in the different parts of the body. Therefore, patient experience lethargy. Also, due to dehydration, the skin and the mucous membrane dry. Dryness is also a clinical sign of the AKI. Central nervous system symptom, mainly drowsiness, headache, muscle twitching, and also seizures. Creatinine also increased, anguria or decreased urine output, and fluid retention, and SOB. Chronic kidney disease, that is the second type of kidney failures or renal dysfunction. CKD is defined as persistent impairment of kidney function. In other words, we can also define it abnormally elevated serum creatinine for more than 3 months, or GFR is less than 60 ml per minute, then we can say that it is chronic kidney disease. CKD can be classified on the basis of grading and staging. These are all general causes of CKD. These are all general causes of CKD, except for because the CKD is in actual terms, when the acute renal failure persists for more than 3 months, it can convert into CKD. The underlying cause may be due to obstruction, polycystic kidney, may be due to hypertension, and also recurrent kidney infection such as pyelonephritis. Move on to the next slide, that is stages of CKD. In stage 1, when the GFR is more than 90, when the GFR is more than 90, the CKD is in stage 1. And when the GFR is 60 to 89, then the CKD is stage 2. In stage 3, GFR is 30 to 59. In stage 4, GFR is 15 to 29. And in stage 5, GFR is less than 15. It means that kidney failures occur, and there should be needs of end-stage replacement therapy such as dialysis and kidney transplant. Next is drug nephrotoxicity. It is an important cause of acute renal failure and should be considered anytime following hematopoietic stem cell transplant. The multiple drugs that can cause renal toxicity, which we are should be familiarized with them, but the cyclosporine is the main drug of transplant that we used in our patient, and almost we used for years in our transplant patients. So that should be kept in mind, that it can cause renal toxicity when the levels persistently high. Other drugs which can cause renal toxicity are antibiotics like amphotericin B, acyclovir, cyclophosphamide, aminoglycoside, amikacin, and immunosuppressive agent such as tacrolimus. This is the chart which shows the dose adjustment of nephrotoxic drugs. The dose adjustment of nephrotoxic drugs is very necessary, is very important. The first drug that is very important in our setup, that is cyclosporine, because cyclosporine causes vasoconstriction, also hyperkalemia and hypomagnesemia. the levels of cyclosporine should be adjusted according to dose. Tacrolimus is also very important. The dose adjustment of tacrolimus is also very necessary. Same like cyclophosphamide, because it caused hemorrhagic cystitis then caused acute renal failure. Therefore, dose adjustment of cyclophosphamide is also very important. Same like vancomycin and aminoglycoside, because these are the antibiotics that cause acute tubular necrosis and also result in acute renal failure. The dose adjustment of this drug is also necessary. Acyclovir or ganciclovir, when the CMV treatment is done, they also damage the kidney tubules and also electrolyte imbalance and also diuretics. Therefore, all drugs are nephrotoxic, and the dose adjustment of all these drugs is very necessary. This is the basic workup that we have done. When the creatinine is in rising trend, then the further workup should be kept in mind as follow, that blood test in blood test RFTs, serum electrolytes, LFTs, blood levels of offending drugs, urine test to see the proteinuria and erythrocyte, and also ultrasound to see the renal structure, obstruction, etc. And the final is kidney biopsy. How we can prevent from renal dysfunction? First of all, provide adequate hydration to patients who are at risk of dehydration, and also prevent and treat shock promptly by fluid replacement or blood replacement, and also close monitoring of venous and arterial pressure, and also close monitoring of urine output of critically ill patient to detect any onset of renal failure as early as possible. Blood administration, take precaution to ensure that the appropriate blood is to administer to correct patient to avoid any blood transfusion reaction. Also prevent and treat infection promptly, because they can produce progressive renal damage. Toxic drug effects also very important. Closely monitor dosage, duration, usage, and also blood levels of all medication metabolized or excreted by the kidneys. The next slide is nursing management, that is very important. Monitor 24 hours urine volume to follow clinical course of the disease. Intake output is a very important part of nursing management, generally and especially in the case when the renal output is considered to be compromised. We aim at keeping output more than 2 to 3 ml per kg per 24 hours. That can only be done meticulous calculation. Therefore, intake output monitoring is very necessary. Also, creatinine and electrolyte balance monitoring, and monitoring of ABG's level, because ABG sample carried by the nurse also make sure the sensitization, heparinization of the syringe. Also make sure the proper sample sent to lab within proper and accurate time. And also weight of the patient is very important to provide an index of fluid balance. Also blood pressure to detect any hypertension and hypotension, and also adjust fluid intake to avoid fluid overload. And in the case of dehydration or in the case of angiuria, restrict fluid to 400 ml per meter square per day. In the case of fluid overload, the hyperkalemia can occur, and hyperkalemia can cause cardiac dysrhythmias. Watch for cardiac dysrhythmias and heart failure from hyperkalemia. Therefore, have resuscitation equipment available in case of cardiac arrest. And also, it's our responsibility to watch any infection, urinary tract infection, and remove bladder catheter as soon as possible. And also our responsibility to provide meticulous wound care, and also for high carbohydrates feeding, because carbohydrates have greater protein sparing power and provide additional calories. This is the nursing management of renal dysfunction. The next is medical management of renal dysfunction in the case of hyperkalemia. When the potassium is greater than 7 gm per dl, there should be stop exogenous potassium and give calcium gluconate 10% 1 ml per kg IV over 5 minutes. And also give sodium bicarbonate 1 to 2 MEq per kg IV over 5 minutes. And if these medical management failed, then regular insulin 0.5 unit per kg with glucose 55% in 1 ml per kg over 1 hour should be given. And also Kegslate 1 gram per kg oral or rectally. In the case of hypocalcemia, follow low phosphorus diet and also give phosphorus binders. And also, if the tetany occur, we can also give IV calcium. What is the indication of dialysis? Dialysis when the volume overload and persistently hyperkalemia is present and severe metabolic acidosis is present, and calcium phosphorus imbalance with hypocalcemia, then there should be need of dialysis. These are all references of my presentation. Thank you all for listening. That's it, sir.
Thank you, Samya. That was very nice.
Thank you, sir.
Any questions, comments? Samya, I'm curious, do you actually have 50% glucose?
No, sir. In our unit, not available, only 5%.
Yeah.
And 20%.
Oh, you do have 20% glucose.
No, sir, 10% and 5%.
Oh, 10% and 5%. Okay, okay. So what is the highest concentration of glucose you have in Bangalore? Kaveri or Sandeep or whoever?
We have 25% and 50% we have.
You have 25% and 50.
50%. Yeah, it will come in 100 ml.
Okay. Okay, good. So I'm curious, what is the highest potassium you have seen, Sandeep or Samya or Azra, in patients undergoing transplant? And did you ever have to use a glucose insulin, KXL8?
No, sir.
Go ahead, Samya.
Okay, sir.
Sorry, Sandeep. Yeah, yes, Samya, go ahead.
Sir, in our patient, the potassium level not greater than 6. Therefore, we never used insulin or Kegslate.
Okay. Okay, Sandeep, go ahead.
Like we have seen maximum 6.2, sir, but we have not given insulin. But in some patients, which we have shifted the patient to ICU, there they have used the dextrose and the insulin and calcium gluconate they have used.
Okay. Okay. Any other questions?